will be presenting, sir.
Go ahead.
So artificial reproductive technique, which consists of ovarian stimulation and monitoring, oocyte retrieval, in vitro fertilization, then embryonal transfer.
What is the indication for artificial?
It is the treatment option for infertility, sir.
Infertility. What are the types of infertility?
Sir, female infertility, male infertility, and combined infertility.
Combined infertility. Any other classification? What is primary infertility and what is secondary infertility?
Primary infertility, where the female is not yet conceived for the first time, and secondary infertility, the female might should have at least one conception priorly.
And then waiting for the second one, which is not happening. Okay. Right, very good. Go ahead.
General considerations in providing anesthesia for ART is usually the patient will be ASA1 and healthy, unless if the patient has some special consideration like morbid obesity and known morbidities like renal cardiac morbidities. And some patients will have infective etiology for infertility like tuberculosis and other endocrine disorders like PCOD and thyroid disorders. And the patient will be on treatment for the same, and they'll be taking anticoagulants, thyroid medications, anti-TB drugs, antidepressants, and anxiolytics. Anesthesia considerations are it was previously done by general anesthesia with laparoscopic technique, where the pneumoperitoneum is created and the patient will be in the Trendelenburg position. Nowadays, it is minimally invasive transvaginal approach, sir. And we have concerns regarding laparoscopy, pneumoperitoneum, and Trendelenburg position, wherein laparoscopy with pneumoperitoneum, the carbon dioxide diffuses into the follicular fluid, which decreases the pH of follicular fluid and causes decrease in the fertility rate, and increases risk of air embolism with pneumoperitoneum, and diaphragm irritation, pain, discomfort in awake patients and also in the post-operative period. And intra-analgesia is very important, because if the patient moves during any important steps like puncturing the oocyte or an aspiration, there will be abdominal.
Okay.
And this has some obstetric disease like ovarian hyperstimulation syndrome, ovarian torsion, and ovarian rupture, and management of perioperative pain if the procedure is prolonged or the aspiration is from increased number of cycles. Effect of anesthesia and ARTs, it is based on the method of anesthesia, the drug and the dose we use, combination of the drugs, timing of administration, and the duration of exposure of oocytes to the anesthetic agents. And there will be increased free drug concentrations because of the hormonal stimulation and hypoproteinemia, especially which has high protein bound capacity. So the stability, which has decreased post-op nausea, vomiting, which is the rapid onset and recovery, and it should have less cognitive impairment. Several studies shows that lidocaine affects both fertilization and embryogenesis, and bupivacaine affects only at higher concentrations. Drugs like opioids, benzodiazepines, midazolam has no adverse effects. Opioids like fentanyl, olfentanil, delfentanil has no adverse effects, but morphine shows has a side effect of chromosomal abnormalities. Under general anesthesia, intravenous agents has no side effects, so they are suitable for general anesthesia than the volatile anesthetics, where propofol, ketamine, midazolam, or alternative to inhalational anesthetic. Nitrate which decreases the pregnancy rate, which activates vitamin B12, which is a coenzyme for DNA synthesis. So it is teratogenic and affects DNA synthesis. Volatile agents also have the same property. Study shows it depresses DNA synthesis and decreases fertility rate. And drugs like volatile anesthetics and anti-emetic drugs which acts on the dopamine like metoclopramide, which increase the prolactin level, further leads to decrease in the fertility rate. So anesthetic management, if the patient is cooperative and comfortable with this minimally invasive transvaginal approach, we can prefer intravenous sedation, that is conscious sedation if the patient is comfortable. We can also provide spinal anesthesia, epidural anesthesia, block, general anesthesia at request. Follow the following guidelines, and patient should have been given aspiration prophylaxis the previous day. Which does not affect the fertility rate are being used like midazolam, fentanyl, propofol, ketamine.
So, okay, assisted reproduction. Pardon?
We should provide adequate analgesia both intraoperatively and postoperatively. The most common complications postoperative are hemoptysium, syncope after oocyte retrieval, post-op nausea, vomiting, vomiting, abdominal pain and uterine cramps, incisional pain refer shoulder peritoneum, and this can be managed with heat pads, small doses of intravenous fentanyl. Benefits are usually because it also affects the embryo implantation. For nausea and vomiting, we can avoid drugs acting on the dopamine. We can consider giving ondansetron 0.15 mg IV. Since it is practiced as a daycare surgery, before discharge, the patient should be able to.
This is a very important point. The procedure mostly done as a daycare procedure. Okay? So all
Yes,
the
sir.
precautions of daycare procedure, preoperative assessment, investigations, everything done as outpatient. The patient is asked to come on empty stomach on the day of surgery. And is it done in the regular OT or is it done in a side OT in the adjacent to any theater? It's like a NORA procedure. Hello?
Hear properly, sir.
Is it like a NORA procedure or is it like done in the operating OT properly?
Procedures like egg retrieval and everything require special equipment, sir. In that cases, we go for a sterile OT.
So there is a dedicated room for that, but it may not be a regular OT like thing because it is hardly a 10 to 15 minutes procedure in the experienced hands. So they may not have a proper OT setup. So sometimes it is done in the side room of OT. Am I audible to all of you?
Yes,
sir.
Yes, sir. Audible.
Okay. So that is one of the things. So two things about this is one is it may be a daycare procedure. Second, it may not be done in a regular OT. It is done in a specialized suit with ultrasound imaging, monitors, all that. And nowadays, most of the physicians prefer to do it under paracervical or pre-ovarian block. What is the method of providing paracervical block? How is it done? Any idea? I think Vidya's mic is not working. Visha, are you able to hear me? Can you
Yes,
answer
sir.
the question?
Sir, patient in lithotomy position, and we go by puncturing the sacrococcus.
Puncture in the, it is the fornix, the cervical, okay, cervix of the uterus. You go to the fornix where the vagina merges and bends with the cervix at the 2 o'clock and 6 o'clock position with a long needle, okay, and deposit about 3 to 5 ml of local anesthetic to infiltrate into the vaginal skin as well as the peritoneum. Okay, these are the two structures which are painful. Then under ultrasound guidance, you can inject into the ovary, because the ovarian capsule is also painful, and then retrieve the ovum and transfer it to the dish where you want to fertilize. So in vitro fertilization is retrieval of the ovum from the mother and then introducing the sperm into the ovum in a dish in the lab. So in the test tube, the in vitro means you do it in the laboratory, you process the whole thing, allow the fusion of the sperm and the ovum to form the gamete, and then transfer that gamete into the uterus of the mother. These are the procedures. So you need anesthesia mostly only for oocyte retrieval in the female. And as she mentioned about the infertility both in male and female, what are the infertility conditions which require anesthesia in the male?
So when the sperm count is less than 5 million, then the volume is low, motility is reduced. Morphology of the sperm is less than 2%. Then we azoospermia.
Azoospermia, they don't produce sperms at all. Whereas if there is an obstruction to the flow of sperms through the seminal vesicles, epididymis and the joining the urethra, then there may be accumulation of the sperm in the epididymis. So you may have to puncture that and then aspirate and take out the sperms. That can be done under local infiltration. But in some male, there is a condition called varicocele of the spermatic cord, which will compress the spermatic cord and affect the flow of the semen and the sperms. In those patients, you may require removal of that dilated venous engorgement to relieve the compression. So that can be done under spinal or epidural anesthesia. Or patient's refusal, you have to give GA. It is just like an inguinal hernia incision made in the inguinal region, exposure of the cord, identifying the tortuous varicocele veins in the spinal spermatic cord, ligate them and remove that, and then proceed with that. So these are the conditions where the male infertility patient will require anesthesia. Okay. So a long time back, about 6 years ago, there was a short note question on ovarian hyperstimulation syndrome. Okay. So how the ovaries are stimulated to produce more ovum? What is the drug treatment that is followed?
So they use tablets like clomiphene citrate and letrogen to stimulate the ovaries. Then they'll inject human chorionic gonadotropin injection 36 hours prior to ovulation, sir.
So these drugs sometimes cause the reactions. So it may be mild, moderate, and severe. Okay? So all the bad effects of injecting these hormones are called the ovarian hyperstimulation syndrome. So depending upon the severity, you may have to decide whether you can continue the treatment or withdraw the treatment and proceed with that. Okay? So that is all about the artificial reproductive technology. So all types of anesthesia has been done. And another important thing, when you give anesthesia for the ovum retrieval or oocyte retrieval, that should not affect the formation of the fetus. It should not produce any congenital anomalies in that hormone because of the drugs that we use. So ketamine anesthesia, monitored anesthesia care, spinal, epidural, all these have been proved to be quite useful and safe. And even under general anesthesia, using drugs like propofol and midazolam have all been found to be safe. Okay, so that is how we must choose the correct drugs and try to give this and manage this situation. Now, before going to the next topic of fetal surgery, shall we finish now?